Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Sarah Tinsley, Courtesy Assistant Professor in the Department of Malignant Hematology at the Moffitt Cancer Center in Tampa, Florida. She will be discussing treatment strategies for high-risk and relapsed refractory myelodysplastic syndromes, including key clinical trials, along with nursing implications for patient support and education. This episode is part of a larger educational program titled NEDTalk 2021, Current Therapeutic and Supportive Care Strategies for Myelodysplastic Syndromes. For more information on Dr. Tinsley, along with the link to the complete program, including a downloadable PDF covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what Dr. Tinsley has to say.
So we're going to jump into the higher risk MDS and looking at the relapsed and refractory MDS. We would be remiss if we didn't talk about azacitidine, which really changed our world for higher risk myelodysplastic syndromes. And this was the AZA-001 trial looking at azacitidine, that the lines do separate, and it was statistically significant with 24.5 months compared to 15 months. So it did improve overall survival. And this is the backbone of our current therapy. We also have decitabine phase 3 trial in MDS. And this was looking at the overall response rate and the time to AML transformation or death. And the overall response rate with decitabine was 17%, and it was 0 for best supportive care. So that was statistically significant. There was a 9% complete response rate. Median duration of response was 10.3 months. So this is important when we're counseling patients as to what to anticipate. There was no significant difference in overall survival in the intent to treat population, with the median overall survival of 14 months compared to 14.9 months. And you may be familiar with the doctors saying that we prefer azacitidine because it's been shown to improve overall survival. And that's based on this data where we saw azacitidine with improved survival and decitabine with similar overall survival when comparing the two groups. Now let's talk about oral cedazuridine and decitabine phase 2 study. And this was really comparing the oral versus the intravenous. And what you'll note if you look at this, the curves is that they're right on top of each other. And they were looking at pharmacokinetics, pharmacodynamics, and safety. And so there was really not a difference. And that's what they were trying to see is oral azacitidine similar to intravenous. And so this is the data that shows that we can exchange one for the other. And that's what happens in clinical practice. Now let's talk about combination regimens that contain hypomethylating agents. Again, since we have the data showing that azacitidine improves overall survival, a lot of these are showing things added to azacitidine. So the first is venetoclax and azacitidine, which was a phase 1 combination studies looking at treatment naive and your relapsed refractory MDS patient with ongoing phase 3 studies in the newly diagnosed MDS. We have added magrolimab to it in the treatment naive. We have APR 246, and we have the IDH inhibitors added to azacitidine. You have a 59% really for the overall response rate. And when you break those down, whether they were HMA naive, that was 75%, HMA exposed, or HMA failure, all of these had response rates. And compared with prior studies, the current trials now include our older patients, which is where we see patients diagnosed with MDS predominantly. And they've included more patient-reported outcomes, which makes my heart feel good because I'm a quality of life researcher. So those patient-reported outcomes are really important to help inform decisions about types of quality of life information that they want to know when they start treatment. These are other investigational drugs used in combination with HMAs. And what's really exciting about this is that there are lots of trials. What's really exciting to me about this is that there's a really big unmet need in our higher risk MDS patients, and we're working on it. So there are also therapies surrounding transplant. We have cytarabine-based regimens, cladribine and low-dose Ara-C, alternating with decitabine. We also have low-dose CPX-351, which has been the CPX-351 we're using in AML, secondary AMLs, but this is using it in the MDS population. And then we have other venetoclax-based combinations. Venetoclax combined with fludarabine and busulfan with reduced intensity conditioning, and azacitidine with venetoclax. And then what about oral azacitidine? This is being used as maintenance therapy after transplant. There's a phase 1-2 study of oral azacitidine, also known as CC486, as maintenance following transplant. The doses are 150 to 300 milligrams daily for 7 days or 14 days every 28 days. Thus far, it's been shown to be safe and well tolerated. The pharmacokinetics are not significantly altered by other medications, which is exciting because we know that can be a big problem, and low rates of relapse and graft versus host disease. There is a randomized phase 3 trial comparing oral azacitidine versus placebo, and that is currently recruiting in the United Kingdom. There are other options for relapsed refractory myelodysplastic syndromes, and there's lenalidomide combination. There's also an azalina study. This is a prospective multicenter phase 2 trial that has 24 patients relapsed post-stem cell transplant, and 58% of them had MDS. The treatment consisted of 5 milligrams of lenalidomide daily for 21 of a 28-day cycle, 8 cycles of azacitidine, the normal dose in 75 milligrams per meter square per day on days 1 through 7 every 28 days, and 3 DLIs with increasing T cell dosages. And the response rate was not bad, 58%, partial responses of 10%. These are other ongoing studies in higher risk MDS. And again, it's pretty exciting that we have ongoing studies to try to meet that need for our higher risk MDS. And the purpose of the International Prognostic Scoring System, the revised version, I explain this to patients as this is the way we stage your disease so that we know how to treat it appropriately. And what are our goals? We think of MDS as 2 big buckets. We have lower risk MDS and we have higher risk MDS. And that's the way our clinical trials are divided also. And you'll see that the treatment goals vary. With our higher risk patients, we're looking at quality of life measures, but we also really want to delay progression to AML and ultimately improve their survival. With lower risk MDS, we want to maximize the quality of life. Again, quality of life is important research. And we want to decrease their transfusion requirements and improve their cytopenias. And that can lead to improvements in other symptoms. And we want to discuss these goals with the patient. And we want to break it down at their level and use non-medical terms. One of the unmet needs of our MDS patients from a literature review that I did, if they didn't have a good grasp or understanding of their disease, this really increased their anxiety. And we are the ones who explain their disease to them. So we need to make sure that they understand what we're saying. And this is a difficult disease to explain to patients because it's not like breast cancer or prostate cancer where it's pretty clear cut to the patient. This is one you can't really see. Most patients haven't heard of or weren't aware of where their blood cells are made. So just really bringing it at the level of the patient. We also know that there are specific considerations in our older adults with MDS, and we should do a good consult or make our regular consult more focused towards the age-related deficits so that we know how to treat patients appropriately. We want to look at their end organ function and try to reserve that. We need to look at all of their other medications. Because of the drug-drug interactions, we also look at insurance, income, what's the cost of their medicine, do they have a good support system? And it's finding that good balance between under-treatment and over-treatment when we implement treatment, disease-modifying agents. We want to improve quality of life and make them feel better and improve their cytopenias. And then these are things that are more common in our older adults, which most of our MDS patients are older adults. Those comorbidities, multiple medications, malnutrition, frailty, cognitive decline, socioeconomic impediments, and others, psychosocial issues, isolation, loss of functional autonomy. So we really want to understand those so that we can, make sure that that treatment is tolerable and that we can get them through and make things better for them. So we want to develop that trusting relationship with the patient and the caregiver. We want to include their support system in explaining the diagnosis, discuss the treatment goals, what we're trying to achieve really, what the signs and symptoms are of progression, why we need to monitor those blood counts carefully, and individualize that plan. There are online sources of support and information, and we can assist with that coordination of care with other healthcare providers. We can refer to the MDS Foundation. There is an app that's tailored to the MDS care. They also have patient support groups, provide information on the clinical trials, and help patients identify those centers of excellence for myelodysplastic syndrome. And again, focusing on the interventions to maximize quality of life and clinical trial enrollment. This is how we make progress.
Thank you very much, Dr. Tinsley, and thanks to you, the listeners, for joining us. As a reminder, view the full program, NEDTalk 2021, Current Therapeutic and Supportive Care Strategies for Myelodysplastic Syndromes, and to download the associated PDF from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.